A very good evening to one and all present here. I would like to take this opportunity to thank the WIMS Anesthesia Alumni Academics for giving me this opportunity to speak upon the recent advances in blood transfusion practices. I'm Dr. Varsha. I'm coming from Department of Anesthesiology at Saptagiri Institute of Medical Sciences. Giving an overview of what are the topics covered in this talk. Firstly, I'll be just briefly touching upon the transfusion triggers in normal surgical scenarios or trauma scenarios, and then go ahead to define the massive blood transfusion. What are the techniques and treatment protocols to follow? The complications that are associated with them. If we have other alternatives, that is in form of oxygen therapeutic agents, and their pros and cons. So coming to transfusion trigger. In scenarios of acute anemia, which we usually face in our OT practices, if there is a surgical hemorrhage, then any hemoglobin value that is less than 8 gram percent will warrant for blood transfusion. Whereas if a patient has trauma, then there is no time for us to go for lab-based investigations and based on that to transfuse the patient. So we go for acute clinical signs, wherein if we will see if the patient has hemorrhagic shock or inadequate signs of inadequate oxygen delivery. Based on that, we'll be transfusing blood. In patients who have non-surgical, non-trauma hemorrhages, who are critically ill and who are in septic shock or late sepsis, a cutoff of less than 7 gram percent will warrant for blood transfusion. But if the patient is in early stages of sepsis, showing inadequate signs of signs of inadequate oxygen delivery, and also if the patient's coronary blood supply is getting hampered in the form of acute coronary syndrome or ischemic heart diseases, then we take a higher cutoff of 9 gram percent. If a patient is suffering from chronic anemia, unfortunately, we do not have a clear cutoff wherein we have to start the transfusion. But in clinical practice, what we follow is any hemoglobin value that falls less than 6 gram percent warrants for blood transfusion. Coming to massive blood transfusion. What is massive blood transfusion? Definition wise, we will define it in either the amount of external sources of blood, that is in form of PRBC, we are replacing to the patient, or we speak about how much of the blood volume of the patient was replaced in a given point of time. So first coming with the number of units of PRBCs used. So if we are transfusing more than 10 units of PRBCs within 24 hours or greater than 4 units of PRBC in an hour, then we call it a massive blood transfusion. But if we are replacing more than or we are giving more than 20 units of PRBC in 24 hours, then it is an ultra massive blood transfusion. In terms of total blood volume, if we are replacing one entire blood volume within 24 hours or greater than 50% of the total blood volume in 3 hours, it warrants to accept it as a massive blood transfusion. The drawback with this is that everything is spoken in terms of 24 hours. That is a very long duration. And the blood loss which is happening is real time. We need to assess, take decision, and transfuse the patient at that given point of time. So duration of 24 hours is quite long and not feasible for us to take a decision. So in pediatric population, the data is sparse, but despite that, what we know and practice now is that there should be transfusion if the transfusion is greater than 50% of the total blood volume in 3 hours, or we are replacing total of greater than 100% of the total blood volume in 24 hours, or there is an ongoing replacement of the blood loss for the child, which is at a rate greater than 10% of the total blood volume per minute, then all these things we take it as activating a massive blood transfusion. So in what situations we face the necessity for massive blood transfusion? Those are, one is whenever there is trauma related bleeding, obstetric hemorrhages, major surgeries, gastrointestinal bleeding. These are the situations we see in our day-to-day practices. There is an exhaustive list which can't be covered, but in our practice, these are very common. What are we aiming to achieve with this transfusion protocol being in place is that we want to maintain a hemostasis for the patient, maintaining the blood volume so that there is no critical hypoperfusion in the patient, And meanwhile, we also want to maintain the coagulation factors and platelets of the patient such that there is no excessive clotting, nor there is no clotting and leading to excessive bleeding. But if we are overzealous, probably we might go the other way around, causing an overzealous resuscitation, wherein there will be an increased arterial and venous pressure, subsequently leading to dislodgement of the hemostatic clots that were there in the endothelial damaged tissues. So that again causes an excessive bleeding. So the criteria to activate massive blood transfusion is that, see, the previous ones were in terms of replacement. So when do we know that this patient is requiring a massive blood transfusion is that we will see clinical signs and we will grade them. The first one is the assessment of blood consumption score, ABC score, wherein we will be taking into consideration the systemic blood pressure of the patient, which is less than 90 mmHg, a heart rate that is greater than 120 beats per minute, a positive fast scan, or a penetrating torso injury. Each of them are given 1 point, and if the total score goes at 2 or greater than 2, then it warrants for activating blood transfusion. But with other clinical or hemodynamic signs, we can go for massive blood transfusion. That is when there is persistent hemodynamic instability, there is active bleeding that is requiring surgery or angioembolization, or there is blood transfusion that has been activated as soon as the patient has reached the hospital, that is in the trauma bay itself. Are there any contraindications for massive blood transfusion? There are no absolute contraindications. In fact, our aim is to save the patient's life, but there are relative contraindications, especially in patients who do not want to accept external blood products, such as patients who follow the Jehovah's Witness and other such practices. So we have to respect the patient's decision making and go ahead to replace blood volume accordingly. So how to go about in a patient who has come with either trauma or surgical hemorrhage, how do we go about activating this massive blood transfusion? First thing, we have to keep a few things ready. One thing, we will prefer to have large bore IV cannulas, that is at least a 14 gauge is good, 16 gauge is also okay. A central line is good, but with Hagen-Poilier's law being in place, we see that the rate of transfusion of blood in a central line would be slightly lesser than that of the cannula. But central line helps us to have a real-time monitoring with CVP and also helps us to take all the lab values from the blood samples that we can access with the central line. The other thing that is important is that we should have effective communication with the blood bank. That is, they should know if we have activated a massive blood transfusion, what should be done, how many products should be released, and at what rate. And there should be sufficient trained personnel who should be available so that there is transport of the blood products without any time loss from the blood bank to the patient, and also to get lab values at the earliest. And then to bridge that time for which the PRBC will be available, we'll have to supply with colloids and crystalloids. Their adequate supply of these should be there with infusion sets available. And then we should have blood warmers, inline fluid warmers, surface warmers, and also in the blood bank, in the refrigerator, there should be a minimum of 8 units of O negative PRBCs and 8 units of AB group plasma. When we are transfusing, what all should we be monitoring? First is core body temperature should be monitored continuously. Then arterial blood pressure monitoring should be done. Invasive arterial blood pressure is better. And then we should have in our hands the IV calcium preparation, anticipating hypocalcemia because of chelation. And also we should have infusion pumps and pressure bags for providing rapid blood infusions. Then what do we test while giving the blood at this rate? We'll be going ahead with checking the ABGs as often as possible, and then every 1 hour, if not feasible, at least every 2 hours, the CBC, electrolytes, and lactates of the patient. If thromboelastography is available in our institution, it should be utilized because it gives us a real-time assessment of the clotting status of the patient. Then, Okay, we are ready with all these things. What do? We have to activate the blood transfusion. It should be done by the primary physician. So after transfusion of 4 to 10 units, we have to call for a massive blood transfusion. There should be institution protocol that is already predefined and set. Based on that, the PRBCs, FFPs, and FFPs or cryoprecipitates and platelets will be issued. That is either in the ratio of 1:1:1 or 2:1:1, which is prescribed by the normal practice. But each individual institute should have its own practice. Nobody should be in a confusion when such situations occur. The drawbacks or limitations is that it is non-standardized. Therefore, if a clinician is from another institute and they've just gotten in and activated a massive blood transfusion, or the blood bank personnel is new, they may not know the protocol, and it might lead to wastage of products. And also, if we have initiated a massive blood transfusion protocol, but then due to certain reasons, we no more either require the blood products or cannot infuse to the patient, then again there will be wastage of the blood products, which is a precious commodity. So, what is the end goal of transfusing so much blood? First thing is we need to achieve a mean arterial pressure of around 60 mmHg or greater, a systolic blood pressure of 80 mmHg or greater, a hemoglobin level of 7 to 9 gram percent, or a near normal INR, platelets greater than 50,000, a normal pH, core body temperature of greater than 35, and we need lactate, if possible, less than 2 milli equivalents. So problems that occur with volume resuscitation is that either we may be too cautious and we may cause inadequate resuscitation, or we may be overzealous, causing overperfusion of the patient. These overzealous resuscitation can then lead to transfusion-associated circulatory overload, interstitial edema leading to abdominal compartment syndromes, and dilutional coagulopathies. During any blood transfusion, what we should look out for is acute reactions and delayed reactions, both of which are caused by two causes, either immunological or non-immunological. We will see in terms of signs and symptoms that the patient presents with and what diagnosis we can place them with. So if the patients are having small variations in vital signs, then usually it is normal. It is a typical response. There is nothing that needs to be done. But if the patient has hives and itching, then it might be a mild allergic reaction. Watch for it. It might go in for anaphylaxis, so we have to continuously monitor the patient. Next comes fever and chills. That alone, it will be febrile, non-hemolytic reaction. It is not too severe. So if fever is accompanied with hypotension, then we have to diagnose it to be either acute hemolytic reaction or bacterial contamination leading to infection of the patient. Next, if hypotension is accompanied by dyspnea, then it can be because of anaphylactic reaction or it can be because of acute lung injury. If dyspnea alone is there, it may be because of volume overload. So other biochemical changes that can happen is there can be citrate toxicity and alkalosis, hyperkalemia, hypomagnesemia, and acidosis. And because we are giving large volumes of external fluid, not having enough time to bring it to the temperature of the body, we can cause deliberate hypothermia. So late complications are that there can be trali which is persistent at least up to 7 days. Then there can be systemic inflammatory response syndrome, sepsis, thrombotic complications. Coming to trali, it is usually a 10 marker for postgraduates. They may take a note. This is because of it is an immunological reaction. This is because of the leukocyte antibodies that are present in the donor blood, and they are responding and attacking the HLA antigens of the recipient patient, a recipient of the blood. So this causes interactions between the bioactive lipids, and then the endothelium of the alveoli and the vascular barriers are broken. So there is increased permeability leading to pulmonary edema. So it is a form of non-cardiogenic pulmonary edema. Here in this picture, we can see the changes of the patient before transfusion and after transfusion, showing a lot of infiltrates that have entered into the lungs. So how do we diagnose them? The clinical signs and symptoms are almost similar to that of ARDS. They occur within 1 to 6 hours of receiving plasma containing blood products. The more the units transfused, the more the chances of rally. It has acute onset dyspnea. The patient will have acute onset dyspnea and severe hypoxemia. It can be associated with fever, chills, strikers, and may or may not have hypotension. So if we intubate, we can see fluid in the ET tube, and then we can see chest infiltrates. But the partial pressure of oxygen will usually return back to normal within 48 to 96 hours. And the hypoxia and chest X-ray, the infiltrates that we see, they need some time to come back to normalcy. They may actually require at least 7 days to come back to pre-transfusion levels. So what is TACO, or transfusion related or transfusion associated circulatory overload? It is an acute pulmonary edema solely occurring because of volume overload. So along with the signs and symptoms that was occurring in Raleigh, we have the patient has severe headache, hypertension, and signs of congestive cardiac failure. What we can do is transfuse slowly, which seldom can occur if we are actually activating massive blood transfusion. But the treatment is to stop transfusion and treat the patient with diuretics. So all the previous described techniques are to replace the lost blood. What can we do to stop the ongoing blood loss? Is that one thing we can use activated factor 7 at the given rate, and we can use antifibrinolytic agents such as tranexamic acid. It has found that in studies, they suggest that tranexamic acid, when it is given within 3 hours of any insert or hemorrhage that is occurring, the morbidity and mortality is much lesser in patients who did not receive tranexamic acid. So it is definitely fruitful. So we have problems when we are transfusing blood. One thing is blood product readily may not be available. We need compatibility testing to be done. So it takes some time. Storage and transport is a problem. There are individuals who do not want to accept blood transfusion. So what do we do in such situations? There are options in the form of oxygen therapeutic agents. These are newer agents that are coming into market. They are in their early stages of scientific research, but they do have promising results. So they are also called as artificial blood. They are not a complete substitute of blood. They can only provide the function that caters to oxygen transport to the tissue. So in this the therapeutic agents, the options we currently have are perfluorocarbon-based blood substitutes, hemoglobin-based blood substitutes, and PE glycated hemoglobins. So coming to perfluorocarbons, they were first described as early as 1966 by Clark and Gollan. The plus point was that they are able to in an emulsified state, wherein they can be infused into the intravenous space. They are able to dissolve gases better than most liquids. The uptake and release of oxygen, therefore, is unaffected by temperature or environment or pH and so on and so forth. And the oxygen concentration solely depends upon the partial pressure of the gas, that is oxygen, in a given area. So keeping these in mind, the therapeutic agents which came into market were Flusol, which was one of the first ones to come into the market. They were used in Japan and United States, and they have FDA approval, but they had to be discontinued due to side effects and limited success. I will tell why later. And then oxygen came with a similar profile. They were also not approved by FDA, and they were discontinued because of the cost that is required for its production. Next came the oxycide and so on. They are still in their early stages of clinical trials, reaching phase 2 trials. They still need a lot of surgical, scientific research to be done for it to be released in the market. What are the drawbacks of using these PLCs? They're expensive. The manufacturing issues are there. They only deliver 0.4 ml ml of oxygen per 100 ml of blood. So all the it looks so good in theory and by chemical structure, but when put into clinical practice, the oxygen delivery capacity is much lower than what was anticipated. So it requires an external source of oxygen, and the oxygen carried by the substance will be unloaded way before it reaches the microvasculature. So it can cause tissue hypoperfusion and hypoxia. When it comes to metabolism, if they have slow metabolism with metabolites remaining in the circulation for months together, And they also cause temporary thrombocytopenia and fever. They have a short stability time also. So all these things taken into consideration, most of them are being withdrawn from the market. Then came the hemoglobin-based blood substitutes. They also have similar oxygen carrying capacity but minimal adverse events as compared to the previous product. And again, it does not have to depend on pH and temperature. It only depends on the partial pressure of oxygen or carbon dioxide. In this category, polyheme was introduced, hemopure was introduced. All of these are in their phase 2, phase 3 clinical trial levels. And heme assist hemolinks are the newer ones, which are there. And again, they are all in the clinical trial phases. Most of the trials are occurring in the United States. What are the drawbacks of these hemoglobin components? That is that they have nitric oxide scavenging that occurs. They cause nitric oxide scavenging, which causes vasoconstriction. Therefore, there is tissue hypoxia, and this leads to systemic hypertension and pulmonary hypertension. The hypoxia itself is deleterious. The main reason for using this was to provide oxygen, rather it's causing the hypoxia. So the other side effects were gastrointestinal distress, flu-like symptoms, nephrotoxicity, and if it crosses the blood-brain barrier, it has the potency to increase the intracranial tension too. So it can't be given in patients who have polytrauma, especially traumatic brain injury. Coming to PE glycated hemoglobin. It was designed to minimize the vasoactive effect the previous hemoglobin-based products were having on the microcirculation. So the advantage was that at lesser partial pressure of oxygen, it was having higher affinity for oxygen, minimal nitric oxide scavenging, and increased molecular homogeneity. So reactions were much lesser. In this category, we have two drugs that are released into the market again in their phase 2 or 3 trials. Hemospan is still in its phase 2 trial in Australia and Brazil, not in clinical use as of now because of production costs. There is sanguinate, which is being used in United States as an orphan drug that is designated by FDA, wherein we can use this drug if there are no other options available and only this drug is available. In that condition, it is being used for patients who have vaso-occlusive crisis such as sickle cell anemia. So take home message is that massive blood transfusion, we may not be facing it every day, but it is an uninvited guest which needs to be treated in real time. So before this occurs, we should have a priorly well planned and well thought of protocol so that when it is activated, every person that is involved knows what exactly their role is and what is the rate of transfusion that is required for the patient, when to start, when to stop it. It requires multi-personnel coordination. The current guidelines are varying between 1:1:1 ratio or 2:1:1 ratio in terms of blood components. So we should be aware of our institutional protocol wherever we are working, and we have to be able to teach our juniors who are coming or new colleagues who are coming into the institute about the protocols. And then if we are going in for massive blood transfusion, we have to anticipate even the adverse events and proactively tackle them early. Thank you.